Question 1. Scenario question. Dr. Stevens is a physician in a busy internal medicine practice. One of his patients, Mr. Thomas, presents with multiple symptoms including high blood pressure, uncontrolled diabetes, and a persistent cough. During the consultation, Dr. Stevens documents the diagnoses as essential hypertension, type 2 diabetes mellitus, and chronic bronchitis. He also notes that the hypertension and diabetes are controlled. Dr. Stevens orders laboratory tests for Mr. Thomas and prescribes medication for the conditions discussed. What should Dr. Stevens do next when assigning I10 codes for these diagnoses? A. Code only the primary diagnosis of hypertension and leave the other conditions uncoded. B. Use combination codes for hypertension with uncontrolled diabetes and separately code the chronic bronchitis. C. Assign separate codes for each condition and ensure that uncontrolled is specifically noted for both hypertension and diabetes. D. Assign code for essential hypertension and another for chronic bronchitis without considering the type diabetes. Answer. C. Assign separate codes for each condition and ensure that uncontrolled is specifically noted for both hypertension and diabetes. Explanation. When coding for multiple conditions such as hypertension, diabetes, and chronic bronchitis, it is essential to code each condition separately unless a combination code is available. In this case, hypertension and type 2 diabetes, it should be coded separately. However, it is critical to include the descriptor uncontrolled in the coding for hypertension and diabetes to accurately reflect the patient's condition. Chronic bronchitis J should also be coded separately as it is unrelated to the diabetes or hypertension in this case. This aligns with I10 guidelines for accurate code assignment and documentation. Uncontrolled is an important part of the patient's diagnosis and should be captured for both hypertension and diabetes. Question 2. Which of the following best describes the role of CCS codes in the medical coding process? CCS codes are used exclusively for inpatient hospital services and are not used for outpatient coding. CCS level Roman codes are used for services, supplies, and equipment not covered by EPT codes. CCS level I codes are used only for outpatient physician office visits and do not apply to hospital settings. DCCS codes do not include drug-related codes, which are all covered by I10. Answer. BATCS level codes are used for services, supplies, and equipment not covered by APT codes. Explanation. ATCS Healthcare Common Procedure Coding System. Codes consist of two levels. Level I codes are identical to CPT codes and are used for physician services, including diagnostic and surgical procedures. However, HCS level codes are used to report non-physician services such as equipment, supplies, drugs, and certain ambulatory services not included in the CPT codes. These codes are important for billing and reimbursement purposes, particularly for services outside of standard physician procedures, such as durable medical equipment, DME ambulance services, and drugs administered during outpatient procedures. Therefore, HCS level codes help ensure comprehensive reporting of medical services and not captured by EP. Question 3. Which of the following is true regarding the use of modifiers in CPT coding? A. Modifiers are only used for diagnostic tests and should not be used in surgical codes. B. A modifier can be used to indicate that a procedure was performed in an unusual or unplanned manner, such as an extended operation or a bilateral procedure. C. Modifiers should never be used when the procedure code is not an exact match for the documentation provided. D. Modifiers are used exclusively by anesthesiologists, should not be used by other healthcare providers. Answer. B. A modifier can be used to indicate that a procedure was performed in an unusual or unplanned manner, such as an extended operation or a bilateral procedure. Explanation. Modifiers in CPT coding are used to provide additional information about a procedure without changing the original code description. Modifiers help to explain circumstances such as whether the procedure was bilateral, performed in an unusual manner, required additional time or resources, e.g., a modifier 22 for a procedure requiring more effort than usual. This allows for more accurate reporting and reimbursement, especially when there are variations from the standard or typical procedure. For example, modifier 50 indicates a bilateral procedure, while modifier 22 may be used when the procedure was more extensive than usual. Modifiers should be used correctly to avoid correct billing and ensure compliance with coding guidelines. Question 4. Dr. Jackson is a cardiologist who sees a patient, Mrs. Miller, for a follow-up visit after recent myocardial infarction. The physician documents that Mrs. Miller is currently stable with no new symptoms. but her past medical history includes type 2 diabetes, hyperlipidemia, and hypertension. During the examination, Dr. Jackson also documents that the patient's blood pressure is well controlled with current medication regimen, but her diabetes is still somewhat difficult to manage. Additionally, Mrs. Miller reports that she has been experiencing occasional chest discomfort, though her ache and laboratory tests appear normal. How should you code for the diagnosis in this case? A. Code only for the myocardial infarction as the primary diagnosis and leave out the chronic conditions. B. Code for the myocardial infarction as the primary diagnosis with additional codes for the patient's diabetes, hypertension, and hyperlipidemia. C. Only code for the patient's diabetes and hypertension as the myocardial infarction is resolved. D. Assign code for the myocardial infarction and use general code for conditions to cover the rest of her medical history. Answer. B. Code for the myocardial infarction as the primary diagnosis with additional codes for the patient's diabetes, hypertension, and hyperlipidemia. Explanation. The physician's documentation should be coded in a way that reflects both the active and chronic conditions of the patient. Even though Mrs. Miller's myocardial infarction is stable, it is still relevant to the current visit and should be the primary diagnosis. Chronic conditions such as type 2 diabetes, hypertension, and hyperlipidemia should also be coded because they are part of the patient's medical history and are still relevant in managing her cardiovascular health. The key here is to code both the active myocardial infarction and the chronic comorbidities, but these are part of Mrs. Miller's ongoing medical management. It's important to ensure all relevant conditions are coded to provide an accurate reflection of the patient's health status. Question 5. In the context of I2MC coding, what is the correct approach when encountering a diagnosis with multiple possible codes due to ambiguity in the physician's documentation, especially when the condition can be categorized under multiple chapters, e.g., stomach pain, which could be categorized under both digestive diseases and general symptoms? A. Always select the code from the chapter that most directly reflects the primary concern based on the physician's documentation. B. Choose the code that reflects the most specific information, even if it means disregarding the general symptoms. C. Use the other specified code whenever ambiguity arises, regardless of the specific documentation. D. Always choose the code that appears first in the I2MC index as it is the most applicable. And so A. Always select the code from the chapter that most directly reflects the primary concern based on the physician's documentation. Explanation. When faced with ambiguity in physician documentation, the key rule in I2MC coding is to select the code that most accurately reflects the primary diagnosis and reflects the patient's clinical status. This should be determined based on the documentation in the medical record, which should given detail to prioritize the diagnosis. For example, if patient presents with stomach pain, but the underlying cause is gastrointestinal like peptic ulcer rather than a general symptom, the code from the digestive disease chapter should be selected. It is important to follow the specific documentation as it helps clarify the primary diagnosis and avoid choosing an inaccurate or generic code. The use of other specified codes should only occur when the physician has explicitly documented conditions that do not match any of the standard codes. Question 6. A 65-year-old patient, Mr. Robinson, is admitted to the hospital for a routine colonoscopy as part of his annual screening. The physician documents that the procedure was completed without complications and the patient is discharged the same day with no follow-up necessary. However, it is noted that Mr. Robinson has a family history of colorectal cancer, though no other concerning symptoms or findings were observed during procedure. How should the procedure and diagnosis be coded in this situation? A. Use a code for the colonoscopy procedure only as there were no issues found during the examination. B. Use a code for the colonoscopy with the associated family history of colorectal cancer as family history is an important risk factor. C. Assign a diagnostic code for possible colorectal cancer even though no symptoms were found. D. Code only for the family history of colorectal cancer as it is the primary concern for this visit. Answer. B. Use a code for the colonoscopy with the associated family history of colorectal cancer as family history is an important risk factor. Explanation. In this case, the colonoscopy procedure should be coded based on the documentation provided. It is important to code for the procedure performed using the appropriate CPT code for colonoscopy. Additionally, family history of colorectal cancer is a relevant factor. I2MC provides A specific code, Z.0, to indicate a family history of cancer, which can be used as a risk factor for future screenings or procedures. While there are no symptoms or findings that suggest colorectal cancer at this time, the family history of colorectal cancer is a significant factor that may guide future care and screening. Therefore, coding for both the procedure and the family history of cancer is appropriate in this scenario. Question 7. Which of the following is true when coding for outpatient services, specifically in the context of an evaluation and management M code? A. M codes should only be used for inpatient hospital visits and never for outpatient services. B. The appropriate M code should be selected based on the complexity of the patient's condition and the amount of time spent during the visit. C. M codes are not required when physician orders diagnostic tests or procedures during an outpatient visit. D. M codes are only relevant for primary care visits, not specialty care appointments. Answer. B. The appropriate M code should be selected based on the complexity of the patient's condition and the amount of time spent during the visit. Explanation, evaluation, and management. M codes are used to document outpatient physician visits, including office consultations, hospital visits, and more. The key to selecting the appropriate M code is to assess both the complexity of the patient's condition and the time spent with the patient. The complexity of the patient's condition often determines whether the visit is classified as new or established patient, and this affects the level of M code assigned. M codes also take into account the amount of time spent in direct care, with longer visits or more complex cases requiring higher level codes. It is essential to accurately reflect both the clinical complexity and the time spent with the patient to ensure proper billing and reimbursement. Question 8. When coding a diagnosis for a pregnant patient, which of the following considerations is essential to ensure proper documentation and coding? A. A separate code for the pregnancy should only be used if complications arise during the pregnancy. B. Conditions unrelated to the pregnancy should not be coded when the patient is pregnant. C. Any condition that arises during pregnancy, including non-pregnancy related conditions, should be coded as pregnancy related to reflect the patient's status. D. The pregnancy code should reflect the trimester of pregnancy if mentioned, but no pregnancy-specific details are required for diagnosis coding. Answer. C. Any condition that arises during pregnancy, including non-pregnancy related conditions, should be coded as pregnancy related to reflect the patient's status. Explanation. When coding for pregnant patients, it is important to reflect the unique aspects of the patient's condition, as pregnancy affects the medical management and treatment of other conditions. If patient presents with condition during pregnancy, even if it is not directly related to pregnancy, such as diabetes or hypertension, the pregnancy-related condition code should also be included. I2MC provides specific codes for complications related to pregnancy, which should be used when relevant. For instance, pregnant patient with pre-existing hypertension would require both the hypertension code and the pregnancy-related complication code. This ensures that the patient's pregnancy status is reflected in the coding, which has implications for care, risk, and reimbursement. Question 9. Dr. Carter, an orthopedic surgeon, performs a knee arthroscopy on a 50-year-old patient who has been suffering from chronic knee pain due to osteoarthritis. The surgery involves debridement of damaged cartilage and synovial tissue. Post-procedure, the patient is scheduled for physical therapy sessions, and the physician notes that the patient's recovery should be monitored closely due to the nature of the chronic condition. How should procedure and diagnosis be coded in this case? A. Code for the knee arthroscopy and include diagnosis code for osteoarthritis of the knee. B. Only code for the knee arthroscopy, as the osteoarthritis is chronic condition and doesn't need to be coded. C. Code for both the knee arthroscopy and code for the patient's previous knee injuries, as they contributed to the condition. D. Use code for osteoarthritis and code for physical therapy, omitting the arthroscopy code. Answer A. Code for the knee arthroscopy and include a diagnosis code for osteoarthritis of the knee. Explanation. When coding for a procedure like knee arthroscopy, it is important to include both the procedure code CPT and the diagnosis code S that reflect the underlying condition. In this case, the patient's chronic knee pain is due to osteoarthritis, so the I2MC diagnosis code for osteoarthritis of the knee should be included. The knee arthroscopy code should also be documented to reflect the procedure performed. Chronic conditions, such as osteoarthritis, should always be coded when they are relevant to the patient's care, even if they are not the direct cause of the procedure. This ensures that the coding accurately reflects the patient's entire treatment plan and condition. Question 10. A 45-year-old male patient, Mr. Thompson, visits his primary care physician complaining of shortness of breath and fatigue. His past medical history includes chronic obstructive pulmonary disease, COPD, hypertension, and a 15-year history of smoking. Upon examination, the physician documents bilateral wheezing, decreased breath sounds, and mild peripheral edema. A chest X-ray reveals signs of hyperinflation, and orders an arterial blood gas test to evaluate his oxygen levels. How should the physician's documentation be coded for this visit? A. Only code for COPD as the primary diagnosis and exclude the hypertension and smoking history. B. Code for the COPD as the primary diagnosis and include secondary codes for hypertension, smoking, and peripheral edema. C. Code for shortness of breath and fatigue as the primary diagnosis without coding for the COPD. D. Use a code for hypertension and fatigue without coding for COPD or the patient's smoking history. Answer. B. Code for the COPD as the primary diagnosis and includes secondary codes for hypertension, smoking, and peripheral edema. Explanation. The patient's COPD is the primary diagnosis as it is the main condition being managed and contributing to the patient's symptoms. Chronic conditions such as hypertension and smoking history are also relevant to the patient's care, as smoking is a major risk factor for COPD. The physician has documented peripheral edema, which is relevant to the patient's overall condition, likely related to his COPD exacerbation or heart failure. These conditions should be coded to provide a complete picture of the patient's health. The coding must reflect all conditions being addressed in the visit to ensure accurate clinical documentation and reimbursement. Question 11. A 55-year-old woman, Mrs. Green, presents to her physician for an annual checkup. The physician performs a complete physical examination and orders routine blood tests. Her history reveals she has type 2 diabetes mellitus, well controlled with medication. The physician notes that she has been experiencing mild fatigue but attributes it to normal aging. Mrs. Green's blood pressure is slightly elevated, but it is within pre-hypertension range. No other significant findings are noted. How should this visit be coded? A. Code only for the routine checkup without documenting any chronic conditions. B. Code for the routine checkup along with her type 2 diabetes mellitus and elevated blood pressure. C. Code only for the elevated blood pressure as it is the primary concern. D. Use general code for fatigue and leave out the chronic conditions. Answer. B. Code for the routine checkup along with her type 2 diabetes mellitus and elevated blood pressure. Explanation. In this scenario, the physician has performed a routine checkup and the patient's chronic conditions are significant to her overall health. Even though Mrs. Green's fatigue is mild and attributed to aging, it is important to document all relevant medical conditions that may affect the patient's health. The patient's type 2 diabetes and elevated blood pressure, pre-hypertension, should be coded as secondary diagnoses because these conditions are part of her medical history and need to be considered in her overall care and management. The coding should reflect all relevant information for patient care and documentation. Question 12. A 72-year-old patient, Mr. Adams, comes to his physician complaining of increased difficulty walking and experiencing sharp pain in his left hip. He reports that the pain has worsened over the past few months. His past medical history includes osteoarthritis of the hip, hypertension, and a prior hip fracture that required surgery 5 years ago. Physical examination shows limited range of motion in the hip joint and the neck. Reveals degenerative changes consistent with osteoarthritis. How should this encounter be coded? A. Code only for osteoarthritis of the hip and exclude the prior hip fracture. B. Code for osteoarthritis of the hip, including the prior hip fracture and hypertension. C. Code for the sharp pain in the hip as the primary diagnosis, excluding osteoarthritis. D. Code for the osteoarthritis of the hip and any related chronic conditions, but exclude the prior surgery. Answer. D. Code for the osteoarthritis of the hip and any related chronic conditions, but exclude the prior surgery. Explanation. The primary diagnosis for this encounter is osteoarthritis of the hip as it is the reason for the patient's current symptoms and pain. The prior hip fracture surgery is relevant as part of the patient's medical history but does not need to be specifically coded unless it directly impacts the current treatment or complications. Hypertension, being a chronic condition, should also be coded as part of the patient's overall health status. Chronic conditions like hypertension must always be coded when they are relevant to the patient's current health, but the prior hip fracture surgery is not necessary to code unless there are complications related to it. Question 13. A 32-year-old woman, MS. Clark visits her doctor complaining of severe abdominal pain, nausea, and vomiting. The physician diagnoses her with acute appendicitis, which requires immediate surgery. The physician documents that the patient has no known drug allergies and has a history of irregular menstrual cycles, but no other significant medical history. The surgery is performed successfully and the patient is discharged the day with instructions for follow-up care. How should the physician code this case? A. Code for acute appendicitis as the primary diagnosis and include a secondary code for irregular menstrual cycles. B. Code for the acute appendicitis as the primary diagnosis with no need to document irregular menstrual cycles. C. Code only for the surgery and omit the diagnosis of appendicitis. D. Use a code for the abdominal pain as the primary diagnosis instead of acute appendicitis. Answer. B. Code for the acute appendicitis as the primary diagnosis with no need to document irregular menstrual cycles. The explanation. In this case, the acute appendicitis is the primary diagnosis as it directly led to the surgery, while the patient has a history of irregular menstrual cycles. This is not related to the current condition and does not need to be coded for this encounter. The primary focus of the encounter is the appendicitis, which is the reason for the surgical procedure and hospitalization. Chronic conditions or unrelated medical history that do not impact the current condition should generally not be included unless they affect the care being provided. Question 14. A 65-year-old male patient, Mr. Roberts, visits his cardiologist for a routine checkup after being diagnosed with heart failure. He reports no new symptoms, but mentions that he feels a bit more tired than usual. The physician conducts an echocardiogram, which shows no significant changes from the previous test. The physician documents that the patient's heart failure is stable, but he is at high risk. Complications due to his history of coronary artery disease, CAD, and diabetes mellitus. How should the physician code this visit? A. Code for heart failure as the primary diagnosis, including secondary codes for CAD and diabetes mellitus. B. Code only for the patient's fatigue and exclude heart failure or CAD. C. Code for heart failure and coronary artery disease, excluding diabetes as it is stable. D. Use code for routine checkup and leave out chronic conditions. Answer. A. Code for heart failure as the primary diagnosis, including secondary codes for CAD and diabetes mellitus. Explanation. The primary diagnosis is heart failure as it is the primary condition under management during the visit. The physician has noted that the patient's heart failure is stable but at high risk for complications. Since coronary artery disease, CAD, and diabetes mellitus are important comorbidities that contribute to patient's overall health, these should also be coded. This provides comprehensive overview of the patient's medical status and ensures accurate coding. Chronic conditions like diabetes and CAD play a significant role in managing heart failure, so they should be included in the coding. Question 15. A 50-year-old female, Mrs. Wilson, presents to her endocrinologist for follow-up after being diagnosed with hypothyroidism. The physician notes that Mrs. Wilson's thyroid function is stable with her current medication regimen, however she is experiencing weight gain and some mild depression. The physician documents that her hypothyroidism is being well managed, but her depression may require additional treatment. This encounter be coded. A. Code for hypothyroidism only as the depression is unrelated. B. Code for hypothyroidism and include a secondary code for depression. C. Code only for depression as it is the primary concern. D. Code for weight gain and exclude the hypothyroidism. Answer. B. Code for hypothyroidism and include a secondary code for depression. Explanation. In this case, hypothyroidism is the primary diagnosis as it is being managed by the endocrinologist and is the reason for the follow-up visit, while depression is a secondary concern. It is relevant to the patient's overall health, especially given the potential impact of hypothyroidism on mental health. The physician's note indicates that the depression requires additional treatment, so it should be documented and coded as a secondary condition. This ensures comprehensive documentation of all relevant aspects of the patient's health. Question 16. A 40-year-old male patient, Mr. Lawrence, visits his primary care physician with complaints of persistent cough, chest tightness, and wheezing. He has a history of asthma, but reports that he has not needed to use his inhaler frequently. The physician performs A physical examination, noting expiratory wheezing and an elevated respiratory rate. The physician suspects an asthma exacerbation and prescribes a short course of oral steroids. The patient is instructed to follow up in 1 week. How should the physician code this encounter? A. Code only for the asthma exacerbation, excluding the patient's history of asthma. B. Code for asthma exacerbation and include the history of asthma as secondary diagnosis. C. Code for the patient's chest tightness and exclude the asthma diagnosis. D. Use code for wheezing and leave out asthma as diagnosis. Answer B. Code for asthma exacerbation and include the history of asthma as a secondary diagnosis. Explanation. The primary diagnosis for this encounter is asthma exacerbation, as it is the condition causing the patient's symptoms and leading to the prescribed treatment. Although the patient has history of asthma, it should be included as secondary diagnosis because it provides context for the current exacerbation and is relevant to the patient's treatment. Ongoing management. Properly coding both the exacerbation and the history of asthma ensures complete and accurate record of the patient's health. Question 17. A 60-year-old woman, Mrs. Taylor, presents to her gynecologist for a routine screening mammogram. The physician notes that the mammogram results are normal, but the patient has a family history of breast cancer in her mother and sister. The physician recommends that the patient continue with annual mammograms, but does not suggest any other changes to her care plan at this time. How should this visit be coded? A. Code for the routine screening mammogram and include the family history of breast cancer. B. Code only for the family history of breast cancer and exclude the mammogram. C. Code for the normal mammogram and leave out the family history of breast cancer. D. Use a code for breast cancer screening and exclude the family history information. Answer A. Code for the routine screening mammogram and include the family history of breast cancer. Explanation. In this case, the routine screening mammogram should be coded as the primary service as it is the reason for the visit. The family history of breast cancer is important to document because it may influence future screening recommendations and care. Coding for both the screening mammogram and the family history ensures that the patient's risk factors are noted and considered for future care, even though no immediate action is required based on the current visit. Question 18. A 40-year-old patient, MS Davis, visits her physician for a follow-up after receiving a positive HIV test result during a routine screening. The patient is asymptomatic and the physician documents that MS Davis is in the early stages of HIV infection. The physician provides counseling about the importance of regular follow-up care and begins the patient on antiretroviral therapy. How should the physician code this visit? A. Code only for the HIV screening and omit the diagnosis of HIV infection. B. Code or HIV infection as the primary diagnosis and include counseling as a secondary code. C. Code only for the counseling and exclude the HIV diagnosis. D. Code for the HIV infection and the counseling related to the condition. Answer. D. Code for the HIV infection and the counseling related to the condition. Explanation. The primary diagnosis should be HIV infection, as this is the reason for the visit and requires treatment and management. Counseling regarding the patient's condition is an essential part of care, especially for newly diagnosed patients, and should be included as secondary code. This reflects both the medical management and patient education provided during visit, ensuring that both aspects are properly documented and coded. Question 19. A 50-year-old male patient, Mr. Carter, presents to his physician with complaints of dizziness, fatigue, and blurred vision. He has a known history of hypertension and hyperlipidemia. Upon physical examination, the physician notes the patient's blood pressure is elevated at 106/90 mmHg and his cholesterol levels are elevated. An ECG reveals mild left ventricular hypertrophy. The physician diagnosed him with stage 1 hypertension and recommends lifestyle changes along with medication to help manage his condition. How should the physician code this visit? A. Code for hypertension only excluding hyperlipidemia. B. Code for stage 1 hypertension, including hyperlipidemia and left ventricular hypertrophy. C. Code only for the dizziness and fatigue as the primary diagnosis. D. Code for elevated cholesterol levels, but exclude the hypertension diagnosis. Answer. B. Code for stage 1 hypertension, including hyperlipidemia and left ventricular hypertrophy. Explanation. The primary diagnosis is stage 1 hypertension, as it is the condition the physician is managing and addressing in the visit. Hyperlipidemia being a significant comorbidity that contributes to cardiovascular risk should also be coded. Left ventricular hypertrophy is a complication or consequence of the hypertension and also be included. Proper coding ensures that all relevant conditions are documented for appropriate management and follow-up care. Question 20. A 62-year-old female, Mrs. Turner, visits her primary care physician for a routine physical examination. Her medical history includes osteoarthritis and type 2 diabetes. She complains of joint stiffness and pain in her knees, but is otherwise in good health. Upon examination, the physician notes mild joint deformities in her knees, but no other acute findings. The physician documents her osteoarthritis as stable, recommends continuing her current treatment plan. How should this visit be coded? A. Code only for the routine checkup and exclude any chronic conditions. B. Code for the osteoarthritis of the knees and include the diabetes as secondary. C. Code for the diabetes and joint stiffness but exclude osteoarthritis. D. Code for the osteoarthritis of the knees, diabetes, and routine checkup. Answer: D. Code for the osteoarthritis of the knees, diabetes, and routine checkup. Explanation: this encounter includes a routine physical examination, but the physician also addresses the patient's chronic conditions, including osteoarthritis and diabetes. Both conditions should be coded because they impact the patient's overall health. Even though the osteoarthritis is stable, routine checkups should always be coded, but chronic conditions that are actively managed or monitored must also be included to reflect the full scope of care. Question 21. A 48-year-old male patient, Mr. Johnson, presents to his cardiologist for a follow-up visit regarding his congestive heart failure, CHF. He reports that he has been feeling more fatigued than usual and has been experiencing shortness of breath on exertion. His medical history includes hypertension, hyperlipidemia, and coronary artery disease. The physician examines him and notes mild edema and heart rate. An echocardiogram shows a slight decrease in left ventricular function. How should this encounter be coded? A. Code for congestive heart failure as the primary diagnosis and include hypertension and hyperlipidemia as secondary diagnoses. B. Code for shortness of breath and fatigue, excluding CHF. C. Code only for the coronary artery disease, excluding CHF. D. Code for the routine checkup, excluding all chronic conditions. Answer: A. Code for congestive heart failure as the primary diagnosis and include hypertension and hyperlipidemia as secondary diagnoses. Explanation: the primary diagnosis for this visit is congestive heart failure, CHF, as the symptoms and follow-up care are focused on this condition. Both hypertension and hyperlipidemia are chronic conditions that increase the patient's risk for CHF, and they should be included as second diagnoses. These conditions are integral to the patient's cardiovascular health and need to be documented for proper management. Question 22. A 55-year-old woman, Mrs. Harris, visits her primary care physician to discuss her recent weight gain, feeling sluggish and cold intolerance. She also mentions that her hair has become thinner over the past few months. The physician orders a thyroid panel, which shows an elevated TH level and low free. Based on these results, the physician diagnoses her with hypothyroidism and begins treatment with levothyroxine. Should the physician code this visit? A. Code for hypothyroidism as the primary diagnosis and include weight gainers. A secondary diagnosis. B. Code only for the thyroid disorder, excluding the symptoms of weight gain and hair thinning. C. A code for the weight gain and exclude the diagnosis of hypothyroidism. D. Code for hypothyroidism and include all related symptoms such as weight gain and hair thinning. Answer: D. Code for hypothyroidism and include all related symptoms such as weight gain and hair thinning. Explanation: in this case, hypothyroidism is the primary diagnosis because it is the underlying cause of the patient's symptoms. The symptoms of weight gain, cold intolerance, and hair thinning are related to hypothyroidism and should be documented as part of the complete picture of the patient's condition. These symptoms help the physician treat the hypothyroidism and should be included to ensure full and accurate coding. Question 23. A 68-year-old male, Mr. Mitchell, visits his urologist for evaluation of his prostate-specific antigen assay levels, which have been slightly elevated for the past 2 years. He reports no symptoms such as urinary difficulty or pelvic pain. The physician performs a digital rectal examination (DRE) and finds no abnormalities. The physician orders additional imaging and recommends a biopsy to evaluate the potential for prostate cancer. How should the physician code this encounter? A. Code for the elevated SSA and include the DRE findings but exclude the need for a biopsy. B. Code for routine screening for prostate cancer, including elevated SSA as the primary diagnosis. C. Code for elevated SSA levels and the potential need for a biopsy, excluding prostate cancer diagnosis until confirmed. D. Code for symptoms of pelvic pain even though the patient does not report any. Answer: C. Code for elevated assay levels and the potential need for a biopsy, excluding prostate cancer diagnosis until confirmed. Explanation: the primary diagnosis is the elevated PSA level, as this is the main reason for the patient's visit. The physician has noted the possibility of prostate cancer, but since no definitive diagnosis has been made, it is important not to code for prostate cancer yet. The need for a biopsy should be documented as it is part of the evaluation process, but the diagnosis of prostate cancer cannot be coded until it is confirmed by the biopsy. Question 24. A 75-year-old female patient, Mrs. Parker, visits her ophthalmologist for evaluation of blurred vision. She reports that the vision impairment is gradual and worsens over the last several months. Upon examination, the physician diagnoses her with age-related macular degeneration (AMD) and recommends the initiation of treatment with anti-VEGF injections. How should this visit be coded? A. Code only for age-related macular degeneration, excluding the blurred vision. B. Code for age-related macular degeneration and include blurred vision as a symptom. C. Code for cataracts as the primary diagnosis, excluding AMD. D. Code for macular degeneration treatment only, excluding the diagnosis. Answer: B. Code for age-related macular degeneration and include blurred vision as a symptom. Explanation: the primary diagnosis is age-related macular degeneration (AMD), as this is the underlying condition causing the patient's symptoms of blurred vision. The blurred vision is a direct symptom of the AMD and should be documented, but it does not need to be separately coded. Proper coding ensures that the primary condition is addressed and managed appropriately. Question 25. A 42-year-old female, Ms. Rivera, presents to her physician for an evaluation of persistent headaches which have been occurring for the last 3 weeks. She has a history of migraines, but these headaches feel different, with accompanying nausea and light sensitivity. The physician performs a neurological examination and orders an EKG of the head, which does not reveal any abnormalities. The physician suspects a possible tension and recommends lifestyle changes and over-the-counter medications. How should this encounter be coded? A. Code only for the tension headache, excluding the history of migraines. B. Code for the tension headache and include the history of migraines as a secondary diagnosis. C. Code for migraine headache as the primary diagnosis, excluding tension headaches. D. Code only for nausea and light sensitivity, excluding the headache diagnosis. Answer: B. Code for the tension headache and include the history of migraines as a secondary diagnosis. Explanation: the primary diagnosis is the tension headache, as it is the current issue being addressed. Although the patient has a history of migraines, the physician is evaluating a different type of headache that is causing the patient's symptoms. Migraines should be coded as a secondary diagnosis since they are part of the patient's medical history and may affect management of future headaches. Coding for both the tension headache and the history of migraines provides a comprehensive view of the patient's condition. Question 26. A 58-year-old male, Mr. O'Connor, presents to his urologist with complaints of frequent urination, especially at night. He has long-standing history of benign prostatic hyperplasia (BH), which has been stable. The physician performs digital rectal examination (DRE) and finds that the prostate is mildly enlarged. The physician also orders urine flow study to assess the severity of the BH and prescribe medication to help manage the symptoms. How should this encounter be coded? A. Code for benign prostatic hyperplasia as the primary diagnosis and include the symptoms of frequent urination as secondary. B. Code only for the symptoms of frequent urination, excluding the diagnosis of BH. C. Code for the routine checkup, excluding BH and urinary symptoms. D. Code for the BH and include the prescribed medication but exclude the symptoms. Answer: A. Code for benign prostatic hyperplasia as the primary diagnosis and include the symptoms of frequent urination as secondary. Explanation: benign prostatic hyperplasia (BH) is the primary diagnosis as it is the underlying condition responsible for the patient's urinary symptoms. The symptoms of frequent urination and nighttime urination are related to BH and should be coded as secondary. Coding for both the prime condition BH and the related symptoms provides comprehensive view of the patient's health and helps in managing the condition effectively. Additionally, any prescribed medication to alleviate the symptoms should be part of the treatment plan, but it does not need to be separately coded unless specified by the physician. Question 27. A 43-year-old male patient, Mr. Lopez, visits his dermatologist for a follow-up evaluation of his chronic eczema. He reports that his skin condition has worsened, particularly on his arms and legs, and he is experiencing intense itching. The physician performs a thorough skin examination and confirms the presence of eczema, documenting areas of flare-up. The physician recommends a change in his topical treatment regimen and prescribes a new steroid cream. How should this visit be coded? A. Code for eczema as the primary diagnosis and include the itching as a symptom. B. Code for the steroid cream prescription only, excluding the eczema diagnosis. C. Code for eczema, including the symptoms of itching but exclude the change in medication. D. Code for a routine skin checkup, excluding eczema. Answer A. Code for eczema as the primary diagnosis and include the itching as a symptom. Explanation. Eczema is the primary diagnosis because it is the condition the physician is managing. The itching is a related symptom and should be documented, but it does not need to be coded separately. The change in treatment, which involves the prescription of a steroid cream, should be noted in the clinical record, but the primary focus for coding is on the eczema. Current presentation. Question 20. A 60-year-old female patient, Mrs. Green, presents to her oncologist for a follow-up visit after undergoing chemotherapy for breast cancer. She reports feeling well overall with no new symptoms, but is concerned about the side effects of chemotherapy, including hair loss and fatigue. The oncologist performs a routine physical examination and orders a blood test to monitor her blood counts. The oncologist discusses future treatment options and provides psychological support to address concerns about the side effects. How should this visit be coded? A. Code for the follow-up of breast cancer and include the side effects of chemotherapy as secondary diagnoses. B. Code only for the chemotherapy side effects, excluding the breast cancer diagnosis. C. Code for routine cancer screening, excluding the chemotherapy side effects. D. Code for breast cancer and include the patient's psychological support as the primary diagnosis. Answer A. Code for the follow-up of breast cancer and include the side effects of chemotherapy as secondary diagnoses. The explanation. The primary diagnosis is the follow-up visit for breast cancer, as the patient's history of cancer is the reason for the visit. The side effects of chemotherapy, such as hair loss and fatigue, should be coded as secondary diagnoses since they are part of the ongoing management of the patient's treatment. Addressing psychological the important, but it is not the primary reason for the visit and does not require separate coding unless psychological therapy or a psychiatric condition is the focus of the visit. Question 29. A 70-year-old male patient, Mr. Taylor, presents to his endocrinologist for an evaluation of his diabetes management. He reports occasional episodes of hypoglycemia and difficulty controlling his blood sugar levels despite following his medication regimen. The physician performs a detailed examination, reviews his recent blood sugar logs, and adjusts his insulin dosage. The physician also discusses the diet and exercise in managing his diabetes and schedules a follow-up visit. How should this visit be coded? A. Code for diabetes mellitus as the primary diagnosis and include the symptoms of hypoglycemia as secondary. B. Code for hypoglycemia as the primary diagnosis and include the diabetes as secondary. C. Code for diabetes and the insulin dosage adjustment only, excluding hypoglycemia. D. Code for routine diabetes screening, excluding any changes in treatment. Answer A. Code for diabetes mellitus as the primary diagnosis and include the symptoms of hypoglycemia as secondary. Explanation. The primary diagnosis is diabetes mellitus as this is the underlying condition being managed. The hypoglycemia episodes are symptoms of poorly controlled diabetes and should be included as secondary diagnoses. The adjustments to the insulin dosage are part of the treatment plan and do not need to be coded separately unless specified by their physician. Question 30. A 35-year-old female patient, MS Davis, visits her primary care physician for an evaluation of her chronic low back pain. She reports that the pain has been present for several years, but it has worsened recently due to a more physically demanding job. She has a history of mild scoliosis, and the physician performs A physical examination. The physician diagnoses her with chronic low back pain and recommends physical therapy and pain management. How should this visit be coded? A. Code for chronic low back pain as the primary diagnosis and include scoliosis as a secondary diagnosis. B. Code for the physical therapy sessions excluding the back pain diagnosis. C. Code for scoliosis as the primary diagnosis and exclude the back pain. D. Code for back pain and recommend physical therapy excluding the chronic nature of the condition. Answer A. Code for chronic low back pain as the primary diagnosis and include scoliosis as a secondary diagnosis. Explanation. Chronic low back pain is the primary diagnosis as it is the condition being actively managed. The history of scoliosis should be included as a secondary diagnosis because it may be contributing to the patient's ongoing back pain. Proper coding ensures that both the primary condition and relevant medical history reflected in the record for accurate treatment and management planning.